Echo before, has done a terrific job and really is an occupational health person. And he is going to speak today about COVID-19 vaccines. So Chris, are you on?
I am here, yes. I apologize. I'm back in clinic and unfortunately no video on the computer here, so I apologize for that.
No worries at all. We're just excited to have you. So anytime you're ready, I will just pull up your didactic for you and the floor is yours.
Thank you. Well, welcome everyone. It's a pleasure to be back. Previously, I spoke to this group on testing issues when it comes to COVID-19, and I thought as we're winding down, or at least this will be the last session I'm giving, go out with the topic of vaccines, very much on everybody's mind. So I've entitled this, When Will We Have a COVID-19 Vaccine? Or When Do I Get My Life Back? Next slide, please. Before we go into the outline, as a public health physician, this probably reflects my inferiority complex, but when I teach the medical students and I teach them in the first week of their first year of the MD curriculum, and that's intentional to try and get them to understand the public health philosophy. And this perhaps reflects my inferiority complex, but whenever we talk about healthcare, we always tend to focus on all the miraculously high-tech things that we can do. And I don't mean to detract from those in any ways. When patients are sick, sometimes they can benefit enormously from high-tech interventions. But the reality is that overall, at a population level, at a public health level, high-tech really has had very little contribution to the health of our population overall. And I'm struck as we deal with this COVID-19 pandemic, how the mainstays of the tools that we're using to combat it are all very, very simple, all low-tech, and indeed very old. Hand washing was first identified by Ignaz Semmelweis in systematic studies in Vienna in 1847. And as you walk through our Health Sciences Center, you can see one of the pillars here, of which I've taken a picture. This pillar illustrates Semmelweis's seminal work to perform systematic studies comparing puerperal fever or maternal sepsis in women who were delivered by people who did or did not wash their hands. He did that work in 1847. Quarantine comes from the Italian 40 giorno, or 40 days, which was how long the Italian city-states of the Middle Ages made ships coming from Asian destinations stay offshore to be sure that these individuals did not carry the plague. Contact tracing is quite old, but in its modern form was developed in the US in the 1930s for sexually transmitted infections. Cloth masks that we're also relying on as a mainstay of our response. If you look at many of the pictures of the 1919 influenza pandemic, you'll see a large number of people wearing cloth masks. Convalescent plasma has been proposed as a treatment. That was studied in 1890 for diphtheria in the first clinical trial of that intervention. And what we're going to be talking about today, vaccination, was done by seminal work by Edward Jenner, a British physician in 1796, who understood that, correctly perceived that individuals who worked with dairy cattle did not get smallpox because of cross-reactivity to cowpox. And the whole English origin of the term vaccination comes from the Latin for cow, which is vacca. And so out of all of the modern medical interventions, the only one really that has made significant contributions at a public health level and saved more lives than any other medical intervention is what we'll be talking about today, vaccinations. Next slide. And so what we'll do today is first discuss issues of efficacy and effectiveness. How are we going to know whether or not this vaccine works for COVID-19? Discuss the current vaccines in development, all 138 of them. No, we'll focus only on 2 of them, but briefly mention the huge number that are in various stages of development. Then talk about some of the challenges and safety issues that might arise as we proceed at this unprecedented pace to develop a vaccine. And then, being the public health physician that I am, switch this to the population level and think about how this is going to work when we start having an effective vaccine at the level of the population. Next slide, please. And this is probably a reminder to most of you, but lay people are often surprised at how long it takes to bring any new intervention to clinical practice. And so this is again material that I cover with the medical students, but just to remind everyone, most drugs and vaccines go through a very extensive and prolonged series of studies identified through these 4 phases. And most of the time, this is preceded by preclinical studies, either in vitro or animal studies, which often go on in and of themselves for years prior to the first human use in a phase 1 study. And a phase 1 study really is not designed primarily to look at whether the intervention, such as a vaccine, works. Its primary goal is to determine whether it's safe in humans, since this is the first time it's ever been administered into a human being. So phase 1 studies really are about demonstrating efficacy, are about demonstrating safety rather than efficacy. A phase 1 study that was one of the first out of the gates for this vaccine is 14 months in length, which started in Seattle in March, to give you some idea how long this takes. And again, that's not really to determine whether the vaccine prevents infection, but just to make sure that it's safe in human beings. And as you move along the phases of a study, you increase the sample size. And so when you go from a phase 1 to a phase 2, you're considerably increasing the number of participants, and now beginning to look at whether or not the vaccine actually prevents infection in a phase 2 study, but often in a more restricted group, generally younger, healthier patients. By phase 3, you're now expanding it to, again, a larger overall sample size and extending that into older populations, perhaps people with other comorbidities, again, to see if it's safe in these other potentially more vulnerable groups and get better information about efficacy. Each stage along a phase 1 study, most interventions drop out, so they never make it all the way along, but should the vaccine make it through all of those 3 phases, each of which is going to take months, then it can be submitted to the FDA for approval and then be available for clinical use. And of course, after approval, the so-called phase 4 studies, which are even larger, will look for other side effects not detected in earlier, smaller studies. The phases can be combined, and so, for example, you'll see me refer to a combined phase 1-2 study that's happening for the COVID-19 vaccine. And to give you some idea that while this is well known in drug development, the FDA has only approved new vaccines for 7 diseases in the past 25 years. More vaccines than 7, but this is not something that's done with anywhere near the frequency as it would be for a drug. Next slide. And with Dr. Hodder on, I almost cringe to try and reduce immunology and vaccinology to one slide. So please forgive me, but for the less expert among us, this is a grossly simplified slide to illustrate how vaccines work, taken from a recent Nature article. And I want to make the point that the body, and I made this point previously with serological testing, the body can make antibodies, but the presence of antibodies is not equivalent to immunity or protection. Only if the body makes neutralizing, or also referred to as functional antibodies, is there any protective effect. And that's only a small subset of the antibodies that a body produces. So shown for you here is the SARS-CoV-2 virus. You're probably familiar with the proteins that it produces, the so-called SNAP proteins, of which S is the spike protein, shown for you here in blue, which docks to the ACE2 receptor in human cells, and that's how it gains entry into human hosts. So only if the antibody interferes with that system by specifically binding to the receptors on the virus and interfering with that uptake to the ACE2 receptors is there going to be a protective effect. And the idea behind a vaccine is to, in essence, trick the body into thinking it's been infected. And therefore, when the real virus comes along at a later time through some exposure, the body has produced and has these neutralizing antibodies available to interfere with the uptake of the virus and protect the human host. Next slide. So how do we know if a vaccine works? Again, simplifying things, we can, in a laboratory setting, culture the virus, extract antibodies from the host, and see if those antibodies are neutralizing in the way that I previously described. That would be reflected in inhibition of viral growth in a culture medium. Of course, a lot of practical challenges to doing that. You would have to be culturing the SARS-CoV-2 virus. That means a biosafety level 3 level of protection, since this is causing a pandemic. And so some technical challenges, not widely available, but it can be done, and it has been done in vaccine development. There is an animal model for COVID-19. The primate model is the macaque, and so you can expose these monkeys to the virus after you vaccinated them and see if there's a protective effect. Again, not many laboratories have these kind of capabilities, but it is possible, and it is being done for development of these vaccines. Ultimately, as the public health physician, the proof of the pudding is in the eating. And so to really demonstrate whether or not this is effective, ultimately you have to determine the vaccine efficacy. As I showed you earlier, that would begin to be addressed in phase 2 and phase 3 clinical trials. And you will, in human populations, vaccinate some people and compare the incidence or number of new cases of COVID-19 infection among those who received the vaccine compared to those who didn't receive the vaccine. Of course, a precondition for such a study would be that the virus is freely circulating in a susceptible population of human beings. Right now in the United States, it would be difficult for you to find such a population because, of course, we're all participating in measures such as physical distancing, mask wearing, etc., precisely to limit and reduce the free circulation of the virus. And so there's this odd paradox that the better those measures are, the harder it's going to be for us to detect and determine vaccine efficacy in a study. And then finally, it's important to bear in mind that in epidemiology, we make a big distinction between efficacy and effectiveness. While those are synonymous in common usage, in epidemiology, they're used very differently. Efficacy means, does it work under the idealized conditions of a clinical trial? Effectiveness is, does it work under the real world conditions of clinical practice that all of you are involved in? And there are many reasons why an intervention such as a vaccine might work in a clinical trial. And then when you get out into the real world where you work, it doesn't work. It might not be acceptable to patients. It might be expensive. It might not be widely available. All of those factors come into play. But I just want to point out that generally speaking, whenever you show that something works in a clinical trial, doesn't necessarily mean it'll work and be effective in clinical practice. Next slide. This is a wonderful website that was pointed out to me by Dr. Heath Dameron, who directs our Vaccine Development Center. And he gave a wonderful grand rounds on this same topic a couple of weeks ago, and I'm grateful to him for this and some of my thoughts for today's presentation. And so you can actually keep track of all of the vaccines under development. You can go to this website and click on the links for any of these vaccines. And it is, as all of you know, I don't need to tell you that the onslaught of information about this virus and this disease is truly overwhelming. I've never seen anything like it in my career. It is difficult to try and keep up with all of this. And so I do appreciate these websites that try and collate all of this information. Currently, according to BioRender, there are 138 vaccines in various stages of development for COVID-19. 122 in preclinical development, so those have not yet hit phase 1 human trials, and 16 in various levels of the phases of human trials that I showed to you earlier. But I think while that's good news, I think we should appreciate, at least I interpret this to mean that we're throwing an awful lot of spaghetti on a wall and hoping some of it will stick. So some of these vaccines, at least to me, seem a bit of a stretch. You'll note the BCG vaccine, which was developed for TB and is the oldest vaccine still in current clinical usage. It's been observed for some time that the BCG vaccine provides some degree of protection, it seems, to viral respiratory pathogens. This was recognized before SARS-CoV-2, and now they're wondering if this can be repurposed to provide some degree of protection to SARS-CoV-2. As you also know or are likely aware, children seem to be less severely affected, which is unlike influenza, and that's one of the perplexing things about this virus. One school of thought is perhaps childhood vaccines like MMR vaccine are providing some degree of cross protection to SARS-CoV-2. But I think you'd agree with me that those sound like a bit of a stretch. I hope I'm wrong, but I don't think anyone thinks that these two vaccines are going to be miracle interventions in dealing with this disease. So 138 vaccines, but some of them I think are a bit of a stretch in terms of whether they're going to afford much benefit. The two that I'm going to talk about are the third row here, the one that starts off AZD, and then the mRNA one, which is I think the fifth row here, which we'll talk about in more detail. Next slide, please. And Heath, in his grand rounds, described this as the most extensive race for a vaccine in human history, and I don't think anyone would dispute that. I've never seen so many people investing so many resources over such a short period of time in attempting to develop a vaccine. This is truly unprecedented. Paul Offit in Philadelphia points out that the record for developing any vaccine to date, so this is what we're hoping to break by a lot, is the mumps vaccine, which was developed in 4 years. That was considered a very rapid pace prior to today's pandemic. Most of the vaccines under development are directed, as I mentioned, toward that S protein that plays a critical role in the binding of the virus to the ACE2 receptor. The federal government has developed something called Operation Warp Speed, hence the Star Trek Enterprise, which has just gone to warp speed shown for you there. And this is an attempt to greatly accelerate the development of a vaccine. Yesterday, they announced that they had narrowed the vaccine candidates down to 5. And this is clearly a redundant effort. Redundant is not bad. Redundant means there are different types of vaccines, all working in parallel for development. That's a good thing. The idea or the strategy being that if one vaccine doesn't work, you've got other vaccines that you're continuing to develop so that hopefully one of these pans out and is successful as these 5 are heavily invested in and accelerated towards development. Next slide. The two that I'm going to mention, as I mentioned, the first is the mRNA-based vaccine, which is from the company Moderna, which is based in Massachusetts, and the National Institute for Allergy and Infectious Disease, directed by the most famous physician these days, Dr. Anthony Fauci. They reported on May 18th that neutralizing antibodies had been produced in 8 out of 8 humans. And if any of my comments as we discuss these two specific vaccines sound a little cryptic and coy, such is the nature of vaccine development. As you can appreciate, whoever comes up with the vaccine that works is going to be a very, very wealthy company, and you want to own stocks in that. And this is, for understandable reasons, an area where patent protection is a major consideration. And so you don't often get the same level of communication that you would perhaps in other areas of science and health that we're used to reading about. They reported that when they disclosed this on May 18th, that the antibody titers, they did not provide specific data, but were at or above levels generally seen in convalescent sera of patients who recovered from COVID-19. Nobody knows quite what that means because widely variable levels of antibodies have been seen in people recovering from COVID-19. The phase 2 study started at the end of May with 600 subjects, and a phase 3 study is to launch after the first week in July with 30,000 subjects. And Dr. Fauci said recently in a JAMA podcast that his prediction is close to 100 million doses to be available in the United States by November or December. So the scaling up is actually preceding or I should say, acting contemporaneously with the investigation of efficacy, which is, again, unprecedented. So all of the measures to widely produce the vaccine have been started now prior to demonstration of efficacy in the phases of human trials. Again, the idea being that once it works, we want to have everything ready to go and not then have to wait for scaling to happen after efficacy has been demonstrated. This particular vaccine is an mRNA-based vaccine. The idea, again, in very simplistic terms, is you introduce an mRNA for the spike protein in the vaccine. It's taken up by human cells. They produce and present the spike protein to the host, and the immune system of the host learns to recognize the S protein through this delivery mechanism, and therefore there's immunity if there is a subsequent infection with SARS-CoV-2. Next slide, please. The other one that most people think is fairly far along is with the company AstraZeneca in collaboration with the Jenner Institute in Oxford in the United Kingdom. Again, that's named after Edward Jenner. I always like it when institutes are named after famous old people rather than big donors. I think it's nice to recognize these giants of the field. And this is an attenuated, non-replicating adenovirus vaccine. And what that means is this is a weakened virus that once it enters into a human cell is not capable of further replicating and reproducing. So there's no prolonged infection with such a vaccine. And again, it displays that S protein. The host recognizes the S protein and produces the hopefully neutralizing antibodies to that S protein to be protective for future infections. This company announced on May 21st that 6 of those macaque monkeys that I mentioned that had been vaccinated and then given a challenge of the virus were protected. In human beings, there's a combined phase 1-2 trial ongoing now with 1,000 subjects. In the highest dose, they dropped that part of the study because the people receiving the third highest dose experienced severe flu-like symptoms, and we'll talk a little bit more about adverse effects shortly. A combined phase 2-3 study is to start in late May, or excuse me, started in late May with 10,260 volunteers, and according to information on their website, they plan to have 300 million vaccine doses available in September. Next slide, please. So that's how we're going to see if it works or not. What about some of the challenges and perhaps safety issues that might arise? The first challenge is one of the 2 leading candidates, as I mentioned, is an mRNA vaccine. Currently, no vaccine in clinical use is based on that technology. So this would be the first mRNA-based vaccine if it pans out. There are also issues of scaling. Remember, this is a vaccine that could potentially be given as widely as the influenza vaccine is. In other words, hundreds of millions of doses for the United States alone, and billions of doses on a global level. And that is a huge logistical effort, which, as I mentioned, is already working contemporaneously with the phases to demonstrate efficacy. But you're already seeing in the media some squabbles over who gets the vaccine first. There was one involving Sanofi and promising the vaccine to the United States, even though that's a French-based company. They then rescinded that and said everyone will be given equal access. But scaling and getting this enormous amount of vaccine at an unprecedented pace is going to be a challenge. Next slide. I hear a lot about mutations, and so the media frequently has these headlines: the virus is mutating, and it sounds like something out of a horrible horror movie, that we could never keep up with this virus because it's constantly mutating in new and nefarious ways. And that's not incorrect. All viruses mutate. These RNA viruses, as you know, hijack the body's own cellular machinery to get our own cells to produce their genetic material. And that's a messy process and results in mutations routinely. However, I think in this case, this issue of mutations is overblown, in my opinion at least. First of all, the SARS-CoV-2 virus is mutating relatively slowly as viruses go. It's been estimated so far in the pandemic that there's about 1 mutation observed per month as this circulates in populations. There's really conflicting evidence as to whether this is increasing either infectivity. Some data from Los Alamos suggested that perhaps it was, but that has not been established, or increasing the degree of virulence. Generally speaking, however, viruses become less virulent. They attenuate over time. In terms, the real issue with respect to a mutation is this going to impact the ability of the vaccine to be protective? In other words, could the SARS-CoV-2 change so dramatically that vaccines are no longer protective because they're no longer producing antibodies that recognize the changed vaccine? What gives me comfort is we've been giving out a vaccine to three single-stranded RNA viruses, measles, mumps, and rubella, since the 1960s, and there's been no evidence to my knowledge that these have become any less effective due to the mutations that occur in these viruses as well. So I think the mutations issue is not a significant one. Next slide. And safety, couple of points to make about safety. Again, this is going to be a vaccine, if we get one that works, that we're going to be giving to everybody. And we're preventing a disease that is self-limited and for which people can stay at home in 80% of the cases. So we really want to think through the safety issue carefully because, of course, the last thing we want to do is cause harm through a vaccine. And unfortunately, I think we are going to see adverse outcomes recognized late in the game that we were simply not able to detect. That has routinely happened with drugs, and it's just a basic statistical power consideration. Very, very rare adverse outcomes are not going to be appreciated until this is in widespread clinical use. You simply cannot do a phased trial of tens of millions of people in order to detect very rare adverse outcomes. I think it's important when we think about these adverse outcomes to always bear in mind competing risks. Those adverse outcomes, as I indicated, would be very rare and should be compared to the known risks from not vaccinating people. So that I think often gets lost in the vaccine debates, that what we're really comparing are competing risks of vaccinating versus not vaccinating. And not vaccinating is not entirely safe. It increases your risk of this disease. Then there's another one that I want to mention that's come up specifically in a lot of the papers discussing a COVID-19 vaccine, and that's something called antibody-dependent enhancement. Next slide. And so this is a concept that's only recently been proposed, although the clinical observations date back to the 1960s, that natural infection or perhaps vaccination can make subsequent infection to different serotypes of a virus worse. It's poorly understood, and again, it seems to be very rare, with the strongest evidence for this occurring in humans in natural dengue infection. We know that this, which is a completely unrelated virus to coronavirus, but we do know and have observed in human populations that individuals who experience one type of dengue viral infection in some cases get much more clinically severe subsequent infections when they're infected by a different serotype of that virus. Next slide. And this is just showing you again that diagram. Again, we need the vaccine to produce neutralizing antibodies to interfere with the binding of the virus to human cells. Next slide. The other possibility is that the vaccine produces non-neutralizing antibodies. And we do know that our bodies have macrophages that are sort of the garbage cleaners of our human bodies, and they routinely come around and clean up these viruses that might have non-neutralizing antibodies bound to them. And so the idea with dengue, which does act through these Fc receptors in terms of how it infects human cells, the thought behind antibody-dependent enhancement is perhaps the macrophages are attacking these viruses and taking them up more readily because of the presence of these non-functional or non-neutralizing antibodies. So rather than protecting the body, it's actually enhancing the uptake of the macrophages and making the clinical infection worse. Next slide, please. When we think about this for SARS-CoV-2, really, I struggled to get the right terms for this slide, but I'm going to call it suggestive evidence. It's not really very strong whether or not antibody-dependent enhancement is operational for SARS-CoV-2. Again, that might just reflect our what we don't yet know about this virus. But as a reminder, you know that there are many human and zoonotic coronaviruses. 4 human coronaviruses cause the common cold. The 3 zoonotic coronaviruses that infect humans, of which this is the most recent one. And so at least because these viruses are circulating in the population, we do know from serological studies that there can be cross-reactivity in the human immune response. So that at least would be a precondition for antibody-dependent enhancement, this idea that you could have been previously infected to a different coronavirus and might now be having this effect with SARS-CoV-2 infection. There's also some in vitro evidence and some animal evidence. There is a coronavirus that causes a disease in cats called feline infectious peritonitis, and has been observed that cats vaccinated against this developed greater fatality when subsequently infected of that coronavirus in cats. And some people wonder if the disease was more virulent early on in Wuhan in China, and that one explanation of that might be that the Chinese populations were previously exposed to other coronaviruses, perhaps through other spillover events earlier, and that what we're seeing is a manifestation of antibody-dependent enhancement. So a lot of that is speculation and conjecture, reasons against thinking that this is important for COVID-19. To date, I'm not aware of any credible evidence that a human has had SARS-CoV-2 infection twice. Now, you will see reports of switching positive to negative to positive PCR, but most people think that that's a test problem rather than 2 infections. SARS-CoV-2 operates through a different receptor mechanism, not the FC receptor that dengue does, that is operational for the macrophage cleanup system. We don't yet know whether this virus infects macrophages at all. There are some labs that have reported isolating the protein in macrophages. That hasn't yet been demonstrated. And as you know, convalescent plasma therapy is being used and studied, and we have not observed this reaction in that setting, which you would predict it to be operational there. It's not yet been seen. So overall, I think antibody-dependent enhancement, I think it's talked about a lot, but I think it's unlikely to be a significant adverse effect as we develop a vaccine. Next slide. And then, of course, we have vaccine hesitancy. That's a WHO term. They've identified it in 2019 as one of the greatest global health threats currently. Recent survey asked people the question, do you plan to get vaccinated against coronavirus? And 20% gave a flat out no. And another study reported around the same time provided a figure of 27%. What's troubling about this data is I've seen vaccine hesitancy grow over my career. It's very frustrating that that is the case. And you can see that younger people here, those under age 60, are actually more likely to refuse a vaccine than older populations. So I think vaccine hesitancy is going to be a growing problem broadly and might pose a problem in getting people to accept this vaccine broadly enough for it to be effective in our population. Next slide, please. So I mentioned at the cellular level how vaccines work. What about at the population level? And again, this is something I go through with medical students because I think we can often misunderstand how vaccines work. Vaccines primarily don't work at the individual level. In other words, generally speaking, the person that you're vaccinating is not going to get the benefit of that vaccine. Rather, we vaccinate as many people as we can so that our entire population is protected. And that's critically important. And often people who oppose vaccines misunderstand that concept because they'll say, well, I wasn't vaccinated and I never got the disease, so therefore the vaccine is ineffective, which is incorrect because that person is getting the protection of herd immunity, which is the resistance of a group to an invasion and spread of an infectious agent based on a sufficiently high proportion of individual members being immune or resistant within that group, from John Last at the University of Ottawa. That's a bit of a mouthful, so let's look at the next slide to see how that works as a figure. This is a figure that I developed for a book chapter that we produced a number of years ago, now in the 2nd edition. And so what I'm showing for you here in 2 boxes are 2 different populations. both of which have an infected index case in red introduced into that population. You can see to the left that there is a very high proportion of susceptible individuals in blue versus immune individuals in black. And note in the box to the left how widely the disease is able to circulate in such a population. Every time there is a stick figure that's blue, the disease can continue to spread. On the other hand, the population to the right has a much lower population or much lower proportion of susceptible blues to black individuals. So again, you introduce a red index case and you can see that it doesn't go very far. If you look at the blue stick figure to the bottom of the red index case, you can see this wall of immune individuals, and the disease can go no further. What's particularly interesting is in the box to the right, that green group, those are individuals who are susceptible but didn't get infected, and they didn't get infected because of herd immunity. For each of those green people, there's a wall of black immune or immunized individuals around them. And that's what herd immunity is. So the whole idea behind vaccination programs is what we need to do is make sure that we have a high enough proportion of immune individuals so that the entire population is protected. That's how vaccines work. Next slide. We can do that in two ways. One is to just recover naturally from the infection. The data so far is that the vast majority of people produce an antibody response, although in varying titers at various time periods after recovering from infection. And so one school of thought, and you probably heard Clay Marsh and others talk about the Swedish experience, or what Tony Fauci called the letter rip approach to COVID-19, which is just don't try and stop it circulating in the population. Eventually, enough people will acquire immunity naturally, and then the disease will spread out. Of course, the problem with that is the case fatality ratio, that you get an unacceptably high number of deaths as the disease moves through the population. The other way that you can do it more safely is through vaccination. Next slide. And so the question is, what proportion of immune people do we need to achieve herd immunity? It's a range, it's not a finite threshold. And not surprisingly, it's directly related to how infectious the virus is. And infections that have higher, I'm going to use the term effective reproduction number. You can, if you're more comfortable with basic reproduction number, you can interpret it the same way. But this is how many cases are spread from any one case. And so those infections that have higher effective reproduction numbers require a higher percent immune. So if you assume an effective reproduction number for SARS-CoV-2 of between 2 and 3 as the epidemic is getting worse, then you would need about 50 to 70% proportion immune, starting at 50%, progressively increasing to 70% to achieve herd immunity in a population to that virus. If we come back to that natural infection, on May 22nd, Governor Cuomo, announced that the serological studies had indicated that about 20% of New York City residents had had the infection. So still a very long way to go to get herd immunity through natural infection, hence the need for vaccines. Next slide. But I don't want you to think that once we get an effective vaccine, we just start vaccinating people and all will be well. Vaccination has to be systematic as part of a broader public health strategy. The greatest accomplishment we've ever achieved with an infectious disease is the eradication of smallpox in 1980. And one of the people who spearheaded that effort is D.A. Henderson, shown for you here. And he really deserves, I think, much more credit than he ever gets for a really important realization. Many people prior to the smallpox eradication effort thought it was impossible, and including Nobel laureates like Macfarlane Burnet of Australia, Nobel Prize-winning immunologist. And basically they said, you can't eradicate an infectious disease because you can't immunize everybody. It's impossible, just logistically impossible. But D.A. Henderson had an important insight, which was that we don't need to vaccinate everybody. If we link an effective vaccine to what is called, in quotes here, a new concept at that time, surveillance and containment, we can eradicate the disease. And of course, he proved himself right. So what he argued when he was eradicating smallpox was that it's not just, we don't need to just be spending money on a vaccine and getting it delivered out into the populations. We need to have public health surveillance systems that alert us very early on when we have a case. And when that happens, and a case is reported, we need to sweep in very quickly and start vaccinating people. Next slide, slide, please. And so this is taken from Ebola viral disease, but the same concept applies. So once an effective public health surveillance system identifies a case, then you do contact tracing, which is something we've been involved in a lot, and quickly identify everybody that that person came into contact with. Then, once we have an effective vaccine, the vaccine is given in a ring treatment or ring approach around all of those contacts, including the contacts, et cetera. So you can mentally visualize that once this case is identified, we swoop in, we vaccinate and create this protective ring around that case and protect the larger population from those greater concentric rings on the other side. This strategy was very effective indeed in eradicating smallpox. And I think once we get an effective vaccine, we shouldn't lose sight of the fact that this has to be part of a broader strategy, which is going to include contact tracing and excellent public health surveillance systems. And if we do that, we can be much more effective in responding to this disease. Next slide, please. And so as I wrap up globally, it is my great concern that we're unfortunately withdrawing from important global partners at a time when we need to be doing the opposite. So as I see it, we have three options as a nation. The first option is what some people have likened to playing ping pong. We can do a wonderful job controlling the virus here and getting it under control. But if another country doesn't do that, and there isn't long-standing immunity, then the disease is going to come back and we'll just be constantly playing ping pong back and forth as the disease moves around the globe. It does not respect our borders. So option one is play ping pong for a prolonged period of time. Option two, we could move to Mars. We could move to another planet and not have to worry about countries that we don't want to deal with. Third slide. Or we can all work together and fight this common enemy. Interestingly, I took this slide from the China Daily, so I do want to point that out. But all countries share some blame and responsibility here. But what we need to do now is coordinate and work together with a concerted response. This virus does not respect borders. And if we apply these measures with an effective vaccine, I think better days are ahead. Thank you very much. And the final slide is my daughter here. This was the last day of school. That is a coronavirus. The spike proteins are in red. And she would make a really good vaccine as she is whacking that virus. She absolutely obliterated the virus. With that, I thank you very much for your participation today.
Thank you so much, Dr. Martin. That was excellent. We did get a few questions in the chat. I know you have to run around 1 p.m. So we can have a few options. We could either go through some of them before you have to head out, or I can put them in the recap and email the questions to you as well.
Yeah, I'll deal with just a couple. Lisa Costello's question about vaccine hesitancy. I've thought a lot about that, and the older I get, I think maybe the mellower I get, and the more humbled I get. I think there are a group of people that when you say to them, what data could I show you that would change your mind on vaccines? And they usually respond by saying, it doesn't matter what data you show me, you'll never change my mind on the hazards of vaccines, and they're going to oppose vaccines. In that case, I would follow the advice of my Irish father who said, save your breath to cool your porridge. If a person's mind could never be changed by data, it means that their opinion is not an evidence-based opinion, and you just won't convince those people. I think what we do need to do, studies continue to show that healthcare providers remain trusted sources of information, and so it's for those people that get confused by conflicting information that they hear from the first group versus us that we need to focus our attentions on. And we need to apply, there's a lot of good information on risk communication. And there's a wonderful guy named Peter Sandman, who's a guru of risk communication. And he talks about how you can effectively communicate risk to lay people. He does it in other settings, but it applies very well to vaccines, because when you think about vaccines, it hits a sweet spot of concern and the subjective factors that impact risk perception are very high for childhood vaccinations. You're introducing some unknown chemical to me. It's all very foreign. I don't feel in control. And those are all factors that Sandman has identified as reasons why people will become concerned about risk. Risk is a very subjective experience. We've got to move away from thinking that I can give you numbers and that, you know, the numbers are going to be reassuring to you. He's shown, and this is why cigarette smokers keep smoking cigarettes. It's a familiar, voluntary activity. And there's an area where we reduce risk perception. So I'd encourage you to look at Peter Sandman's work. There is a group that's always going to oppose it, and there's nothing we can do about that. Other questions?
We did get a couple questions in the chat. So there was one asking, so there's a rapid antigen test available that has a high correlation with PCR for positive about, and not an accurate one for the negative PCR tests, about 80%. So they just wanted to know if there are any downsides to using an antibody test if there is backup PCR to verify a negative.
So there was a lot in that. Generally speaking, we do not yet know what an antibody test means beyond that you were exposed to the virus. I think we'll eventually have clarity on that. But for the time being, a positive antibody test, I think we will get to a point where through a combined series of testing, we'll have better insight and diagnostic value. But right now, the antibody test is primarily a marker of past exposure to the virus, which is valuable, just not diagnostically. And others may want to chime in, like Dr. Hodder. Part of the problem with a lot of these tests is a statistical truth that I inflicted on Dr. Costello and probably makes her still seize, which is the 2x2 table and sensitivity and specificity. When you're trying to test for a rare outcome, and COVID-19, it might sound strange for me to say this, but it would not be unreasonable to assume a prevalence of COVID-19 in West Virginia of 1%. I actually think it's probably lower than that. But in the populations we're testing, that's not an unreasonable estimate. You need extraordinary specificity so that you don't get overwhelmed with false positive test results when a disease is only 1% prevalent. And so I think there are some problems related to test performance. Then there is that statistical truth, which means only with an incredibly specific test can we solve that issue.
Thank you. And they just wanted to clarify that it's an antigen and not antibody test. Is that correct?
That the questioner was asking about an antigen test. So yeah, so that would be a combination of both serology and antigen testing. Is that the question?
Yeah, I think they just wanted to clarify.
Okay.
Thank you. So we got a question from Dr. Costello as well about speaking on the role health professionals should play in combating vaccine misinformation in the public, particularly the COVID vaccine. Yeah,
I think that one I addressed previously. There's another question about what age groups are being enrolled in clinical trials. The Jenner Institute and AstraZeneca has just started enrolling older population groups in their, I believe it's a phase 3 trial that they're going to start this summer. Their earlier study was in younger populations. So typically the older population, say over 60, are part of the phase 3 studies. And precisely because of concerns about safety in that group.
Perfect, thank you. We got another question in saying the recent study in Nature Genetics showed that AZ COVID-19 vaccine used an adenovirus vector grown on monkey cell line and may have integrated monkey genome into the vaccine construct that may render the vaccine ineffective for human use. They just wanted to know what your thoughts were on that.
I have not seen that paper, but again, that would be the same vaccine that I mentioned, the AstraZeneca Jenner Institute collaboration. That's the adenovirus. I don't know if anyone else saw that paper.
I did not see that paper, but you know, adenovirus as a vaccine platform in other settings has really had a checkered past. You might recall that there was an Ad5 platform for the HIV vaccine for the STEP trial that suggested that actually HIV infection was more common in those that got the vaccine versus didn't. Now that, you know, HIV is a very, very different virus, and the theory is that actually that vaccine activated CD4 cells, made it easier to infect. But there was also some issue of whether or not pre-existing adenovirus, you know, we all see adenoviruses, whether pre-existing antibodies might, you know, decrease or lessen the efficacy of the vaccine. So, I mean, I think that these are all questions that are out there, and that's why you do the studies to really sort of see how they perform.
Thank you, Sally. With that, I'm probably going to have to go. I've got a clinic patient waiting. I do apologize, but it was great to see everyone, and thank you very much for joining us today.
Absolutely. Thank you so much. Thank you so much, Dr. Martin. We appreciate it. Were there any other questions out there that you would like to have addressed? Feel free to chat them in. We have a few hub members on as well, so we could have you know, a great open discussion for anything, any topics you'd like to see for the future.
Well, people are thinking, I'll just add, Chris discussed Dr. Semmelweis and his hand washing with clear data that hand washing decreased the incidence of purple infections. The medical profession did not believe him, did not adopt his principle. He was actually later condemned to an insane asylum and died of sepsis. The conjecture is it was a gangrenous wound on his hand, possibly from struggle or from being restrained. And, you know, so I think it just, humans are always skeptical, but as clear as the data were way back hundreds of years ago, he's a hero now, but at the time, nobody believed him. And I always think that that's, you know, sort of informs, there will always be sort of groups that, you know, may not think masks are appropriate or whatever, despite the data. Nothing new.
Absolutely. Were there any other questions? We do have about 6 minutes left. So we got a chat question in asking how everyone feels about opening things throughout the state and risk of an increase in cases.
Where's Lisa Costello? Does she want to respond?
I'm here.
To that?
Yeah, excellent question. Lisa Costello here, calling in from Charleston. I think that we have seen increase in cases in some areas. Some of our case number increase, if you're following the dashboard, is twofold. One, we started reporting what we call probable cases, which are still going through the epidemiologic investigation. And so that case definition is now included in our positives. It also includes antibody testing, and we just had a discussion on that, so that could impact the number we're seeing. And then we did have a pretty significant outbreak in a prison that led to over 100 positives. But there are areas of our state, particularly the Eastern Panhandle, that we have seen ongoing increase in cases. And as Dr. Martin talked about, the need for increased contact tracing along with case investigation, that is happening. I think we're still probably a little early in knowing what these opening strategies and what we're seeing, just given the incubation period of the virus. So I think in another week, we'll see, because we're getting almost about 2 weeks out from Memorial Day, which was really, I think, kind of the big time where we saw a holiday paired with us reopening. So although we're seeing it in some regions of our state, there's other regions that are staying incredibly steady. And we have seen increased testing. There have been multiple community-based testing events that the state has put on, that we have targeted minority communities, but really all communities. Those are continuing to happen. There's more this weekend. And so we have seen pretty positive numbers come out in regards to, when I say positive, I mean not positive tests, but positive in regards to we're seeing many negative tests. So I think that those numbers continue to be looked at very, very closely to see if there needs to be additional measures taken. And then I think ongoing emphasis of those important public health measures that Dr. Martin started his presentation off with that aren't high tech, but potentially could play a significant role in reducing transmission, such as washing our hands, and more recently showing that we really do need to be wearing face cloth coverings, and encouraging individuals to adhere to those type of recommendations. So I think we still have a little bit of time, and by the time we have our next echo on COVID, we'll probably be able to answer that question better to see if we've seen pockets. And really kudos to Dr. Potter and her group for really just tremendous work that they're doing in helping the state be able to better predict where we may be seeing an increase in cases, with works on our R0 and other efforts to help better determine where do we need to be doing that testing, and kind of getting more to what even Dr. Martin talked about in our vaccine approach of a ring approach, but even doing that from a testing standpoint as we continue to learn more about how this disease spreads and where is it in our communities.
Thank you so much, Dr. Costello. And based off of that, there was a question asking, with the increase in cases, are we seeing more hospitalizations and or more deaths?
You want me to take that one as well? So we've actually, I think we have to, in regards to COVID, we're not really seeing more of a utilization. I think what we have to remember is that we are now doing elective procedures again. And so I can tell you, I'm an inpatient hospitalist at W Medicine Children's, and I can tell you that our service is back to pre-COVID. And that's not because we've had a COVID positive case. It's because we're back to where we were before, and that we're having people after elective procedures being admitted, or other reasons for admission. So I think that we're holding pretty steady in regards to pre versus post comeback, I guess, in regards to our utilization of cases. But I do think we're going to have to continue to watch that trend in case there would be a spike, and how do we deal with that, because we are starting to see our hospitals get busy again, solely because they're starting to operate as they were pre-COVID.
Excellent, thank you. And I don't want to put you on the spot again, but we got a question. When you say defined as a recovered case, is that completely asymptomatic or improved patients?
So excellent question. The recovered definition was one that took a significant amount of time to develop, because there are different, I think everyone loved the Johns Hopkins model that came out, and they started to use this recovered definition, which was incredibly kind of, quite frankly, arbitrary, because they just kind of talked at looking at what it was like a time-based, basically after a certain period of time they were recovered, where we've seen in real life that there's been patients who have been intubated for weeks, 2-3 weeks. We've seen patients intubated and then subsequently recovered. So our recovered definition in West Virginia does get to resolution of symptoms. So, and that's part of the case investigation and contact tracing, that is defined.
Excellent. Thank you so much for that clarification. So unfortunately, we've come to the end of the session. So before we close the session and everything, any questions that were submitted and weren't addressed, we'll save for next time. And one quick announcement, our next session will be on June 18th. So keep an eye out for any reminders for that upcoming session. I know Dr. Martin had to jump off, but I wanted to give a big thanks to him again. And thank you to everyone who helped answer any questions and submitted any questions. So thank you all so much, and we will see you guys next time.
Thank you.
Thank you.